HAE is a rare genetic disorder. It's inherited as what we say an autosomal dominant. What that means is that if a person with HAE has children, 1 in 2 children have the chance of carrying that gene and having the condition. It's a condition that causes unpredictable swelling, or what we call angioedema, and that can affect just about anywhere, the periphery, the skin, the subcutaneous tissues. It can affect the gut, so abdominal swellings is one of the very common presentations. And most importantly, it can cause swelling in the upper airway, and that, in fact, is a life-threatening type of swelling. HAE is an inherited disorder, so it's present from birth, but it's rare for infants and very young children to express problems. But some do start having early swellings in early childhood. By the time a child is 9, 10, 11, most will have started to have swellings, and certainly from around puberty, the vast majority of people will start to have their attacks. There have been cases where swellings haven't started until adulthood, but that's pretty rare. So by the end of childhood, almost all patients will have had at least one swelling. Symptoms of HAE are those of swelling. So they're unpredictable. People don't know when they're going to happen. Many have a warning that they're going to start, and it is a slow onset. So they start to get a little bit of pain or tingling, discomfort, tightness, and then the swelling builds to a maximum over about a 24-hour period, and it can take up to 2 to 5 days to resolve. If the swelling's abdominal, patients can talk about crampy, colicky pain. Their bellies may actually swell out and get very hard. They may experience nausea, diarrhea, vomiting, and in profound cases they can collapse because they have so much fluid loss. Swelling in the upper airway, of course, is very threatening, and people are aware of it very early. It's a feeling of a lump in the throat or a difficulty with swallowing, and then obviously it can impact breathing. So it depends somewhat on where the swelling occurs as to what the symptoms are, but ultimately what happens is that part of the body will swell, and it can swell to an amazing degree and be very distorting, very disfiguring, and very painful. Almost every patient with HAE will experience a peripheral swelling, in other words, the hand or the foot, the arm. Very many of them, over 90%, will have abdominal swellings. The laryngeal swellings are the rarest of swellings, in that if you look at all attacks overall, it's about 0.9% are laryngeal, but 50% of patients will have at least one laryngeal swelling sometime in their lives. So that's still awful odds from the point of view of a life-threatening attack. But abdominal and peripheral are far more common. Sometimes there is no trigger. They can just happen spontaneously. But for many patients, they recognise triggers. And the common ones are stress, and that can be emotional or physical stress. Trauma, so knocks and bangs and things like that can cause a swelling at that site. Infection is a common one. Patients generally swell more readily if they have a fever or they're sick. For women, around the time of their menstrual period is a risky time. There are certain medications that will really enhance swelling. So for women, that's the estrogen-containing oral contraceptive pill. There are some high blood pressure medications known as ACE inhibitors that can often promote swellings. But really, overall, it's stress, it's trauma, it's infection. Swellings of HAE are the same. It doesn't matter if it's a child or a male or a female. They can be in any place. There can be swellings in the genital areas, which obviously present differently for men and women, but the swelling is the same, and the frequency and the distribution of swellings are similar for men and women. In general, women suffer more than men, and that is because of the hormonal changes. So around menarche, when a girl starts to have periods, is a very risky time. Perimenopausally is also a risky time for increased swellings, and pregnancy can have a variable effect on HAE. Some women have more swellings, some have fewer, others stay much the same, and the stage of pregnancy can also impact on the frequency of attacks. If it's thought about, diagnosis is easy. We have blood tests that are done, and we measure a number of components. We measure something called the fourth component of complement, or C4, and we actually measure the C1 inhibitor protein. We measure its level, and then we do a functional assay to see how it works. And those three markers together help us differentiate the various types of HAE. The tests are fairly simple. They're very readily available in Australia and New Zealand. So HAE is a very rare disorder, so it's not surprising that many medical practitioners go through their whole practice with never seeing a case. But it is on that list of differential diagnoses for angioedema, and there are features of this angioedema or swelling that are different to allergic angioedema, which is by far the more common cause of swelling or angioedema. The fact that it comes on slowly and that it lasts for such a long time is unique to the HAE form of swelling. The other thing is that it does not respond to the treatments we usually give for allergic angioedema. I think we've done a lot of work in the last decade or so with education to highlight the fact that this is a swelling form and to think about it, because we do have effective treatment now, plus the fact that this can have life-threatening consequences. It's important that it isn't missed. Treatment of HAE comes in a number of ways. We talk about acute treatment, we talk about long-term prophylaxis, and we talk about short-term prophylaxis. We're very fortunate here in Australia that we now have a number of the modern therapies available. So from my point of view, every patient diagnosed with HAE should have acute management on hand. And for the majority, that is a substance called icatibant. Patients are taught how to use it, and it's best used early in an attack to abort the attack and settle it quickly. An alternative to that is an infusion of C1 inhibitor concentrate, or Berinert. That's obviously a little more difficult to administer because it's through the vein. So icatibant is by far more convenient, and the majority of patients can use that. For long-term prophylaxis, we have Berinert as a subcutaneous infusion, and patients are taught how to do that, and they do that twice weekly. So it's replacement therapy, if you like, and it's highly effective. More recently, on the PBS, we have available a drug called lanadelumab, or Takhzyro. And again, that comes as a syringe. It's an injection because it's a monoclonal antibody. And again, patients self-manage this. And that's usually given once a fortnight for prevention of attacks. Older treatment for prophylaxis includes drugs such as danazol and tranexamic acid. Danazol now is pretty hard to acquire, so it's really coming out of the picture. Tranexamic acid is used more by the paediatricians because of its safety. Then we have short-term prophylaxis, which should be available for every patient with HAE, and that's needed to protect them if they're having surgery or if they're having invasive dental work or other procedures where there's instrumentation of the head and neck, such as gastroscopy, for instance. So that involves having an infusion of Berinert intravenously an hour or two before the procedure to bring the levels up to protect them from swelling from that instrumentation. And then patients should have their acute management on hand for afterwards should they have swellings because of the procedure. I think education is vital so that an individual understands exactly what the HAE is, learns to recognise triggers and how to manage those triggers, because that in itself may reduce the frequency of attacks. We, like every patient with HAE, to have their own individualised management plan, which is a written document on a recognisable form, and that's very useful if they need to present to an emergency department, as doctors will recognise the form and follow the instructions that are written there for that individual. Keeping an assessment of attacks is often useful in a diary format. It helps patients understand what might be triggering, and it gives the doctor good insight as to the frequency of attacks so that that can be addressed as well. And patients may need to be stepped up to prophylactic therapy if the attacks are becoming very impactful on their lives. And we also use assessment tools such as quality of life instruments to gauge from the patient's perspective what impact this condition is having on their general lives, not just on the number of swellings.